going forward and talking about another type of obstructive disease, chronic obstructive lung disease, here's a 67-year-old woman with COPD who is evaluated for dyspnea. She denies fever but has productive cough. Her medication is inhaled ipratropium. She has 32 pack years of smoking history. Her respiratory rate is 32. Her pulse is 106, and she's febrile. Her physical exam, she's cachectic. She has rapid breathing, distant heart sounds, increased AP diameter, and expiratory wheezing. So this is typical. And this is typical of a patient, and we're going to talk about these patients and then go back to this case and talk about it again. But this is a typical case of some type of chronic obstructive lung disease. And in this patient, just because of the way she looks, her rapid respiratory rate, that she looks cachectic, she doesn't look plethoric, that usually the diagnosis that these patients have, especially when they don't have the productive cough many months out of the years, usually the diagnosis she would carry is emphysema. So, but let's talk about these diseases, and then we'll go back in this case and discuss it again. So the general concepts are that there's two types of chronic obstructive lung disease: emphysema and chronic bronchitis. Emphysema is really a pathologic diagnosis in terms of the definition means permanent dilatation of the alveoli from the terminal bronchiole to the alveolar membrane. Permanent dilatation and destruction of both the terminal bronchioles and the alveolar membrane. And once these patients develop permanent dilatation and destruction, that's when the DLCO gets affected, versus other obstructive diseases like chronic bronchitis where the DLCO is not affected. Chronic bronchitis, on the other hand, is a clinical diagnosis. Most of these patients have productive cough 2-3 months out of the year for consecutive years. So even though both of our chronic obstructive lung diseases, one it's more of a pathologic diagnosis in terms of the definition of it, and chronic bronchitis is more of a clinical diagnosis. The definition more so for both COPDs is that they have non-reversible obstruction. So when you compare these diseases to asthma, for example, the bronchoconstriction that affects COPD is basically permanent, non-reversible. When I give these patients bronchodilators, I see no change on the PFTs, or the change in the pulmonary function test is minimal. Maybe about 2, 3, 4%, but never more. Minimal. Also, these are non-inflammatory conditions. Unless you're talking about a COPD exacerbation, in the chronic state, chronic obstructive lung disease is a non-inflammatory process. Compare that to asthma, which we said by definition is an inflammatory process. These are non-inflammatory. So these patients don't benefit from chronic use of steroids. Now, there is a small population of these patients, and they're sometimes referred to as asthmatic bronchitis or inflammatory bronchitis, where they have reversibility and they have inflammation, and you could use steroids, but for your purpose, across the boards, COPD is a non-inflammatory condition in the chronic state. That's not the case, though, when they come in with exacerbations. So we have recent studies in the last 7-8 years that show that when these patients come in with an acute exacerbation, I mean when they come in with worsening of dyspnea, they come into the hospital with shortness of breath and hypoxemia and so forth, that at that time, during the acute exacerbation, there's a component that is very inflammatory. Thus, we know that we use corticosteroids in that acute setting to resolve that inflammatory process, but not in the chronic state, only in the acute exacerbation. Cigarette smoking is the main culprit of COPD, and most patients will get it usually in the 6th or 7th decade of life, because it's usually after 30 years of smoking and more that we see evidence of chronic obstructive lung disease. Not all patients that smoke get COPD, so there's other factors here. These people are definitely predisposed, but most patients with COPD, cigarette smoking is a factor. And then we have a rare form, but something that we have to look for because it may be treatable. A form of COPD usually causes emphysema, usually emphysema involving usually the lower lobes mostly in young patients that may have a short smoking history or no smoking history at all, and this is called alpha-1 antitrypsin deficiency. If you're missing your alpha-1 antitrypsin, you don't block these enzymes in the lung that cause chronic inflammation and destruction of the alveolar membrane, and these patients develop emphysema eventually. They're younger patients, so you'll see, a 40-year-old person or a person in their 30s get emphysema. You have to think about this disease. These patients also, we're going to talk about it a little bit later, these patients also develop liver enzyme elevations, transaminitis, because when you have alpha-1 antitrypsin deficiency, these patients develop also a form of hepatic inflammation, hepatitis. So the presentation is straightforward. They have chronic wheezing or intermittent wheezing. They have dyspnea on exertion. This is probably the main complaint that they come to the doctor for, the hospital, and they have productive cough for a few months for consecutive years. That's the typical chronic bronchitis. Patients with emphysema usually don't. They may have a little bit of cough, but they don't have that consecutive for months and months productive cough for years and years. That's the chronic bronchitis, and that's why when we looked at this case, the COPD case that we just did, I said, well, I don't know the diagnosis yet, but it's more likely consistent with emphysema. On the physical exam, what do you find? Well, if they have hyperinflated lungs, you find distant heart sounds, and they mostly do. You may find some bronchi and wheezing. Because these are chronic diseases, when you look at their fingers, you may find clubbing. If the disease has been going on for a long time, it affects the pulmonary hypertension, affects the right side of the heart, and it causes choropulmonality, right-sided heart failure due to pulmonary disease. Now that's a big deal, because now once a patient develops choropulmonality, their morbidity and mortality increases exponentially. So that's a big deal to try to prevent choropulmonality from pulmonary hypertension, and we'll talk about that in a little bit. And the last thing that I put down here, because they may ask you a question about that, a lot of the patients, and especially patients with chronic bronchitis, develop a facial plethora, like erythema around their face. And the reason for this is because their hemoglobin and their hematocrit is elevated. They look really rosy. And the reason why is because they have secondary erythrocythemia. Not polycythemia vera, secondary erythrocytosis. And the secondary erythrocytosis is the most prominent factor, is the chronic hypoxemia, hypercapnia that affects these patients. And probably because a good number of these patients are smokers also at the same time. So if they ask you, what are you likely to find on the hemoglobin hematocrit in these patients, the answer is, I'm likely to find a hemoglobin hematocrit that's elevated. That's what I expect to find somebody that has chronic bronchitis. The chest x-ray is typical. The hyperinflated lungs, the flattened diaphragms, and especially in emphysema, the slender heart that we see. In the ABG, hypercapnia, hypoxemia, the thing to remember is that these patients, especially the patients with chronic bronchitis, fall into that 60-60 group. You know that their CO2 is equal to their O2, right? 60 of CO2, 60 of O2. That's the typical finding. And sometimes if you give them too much oxygen, in this case, they retain CO2. Right? So you get concerned about that low O2, and then you give them oxygen, and you kind of blunt their respiratory drive and they retain CO2. Now that's not, I said blunt their respiratory drive. It's not exactly what happens, but these people retain CO2 when you give them too much oxygen. The labs, we talked about the polycythemia and the pulmonary function test. Every patient with COPD, every patient with asthma has to have PFTs. I've stressed that. These show non-reversible obstruction. If a patient has emphysema, he or she will have non-reversible obstruction plus a decreased DLCO. A patient with just chronic bronchitis will have non-reversible obstruction with a normal DLCO. In clinical practice, most patients fall into a category where they have a little bit of emphysema and a little bit of chronic bronchitis. You don't see this clear-cut picture that I just talked about, but we need to know this for the exams. We need to know that a patient with emphysema, if they have only emphysema, has DLCO that's decreased, and a patient with chronic bronchitis has normal DLCO if they have only chronic bronchitis. And then they look a little bit differently, I told you. Patient with chronic bronchitis has the productive cough, looks plethoric. Patient with emphysema doesn't have productive cough, looks a little bit cachectic. So those are the big differences we have to remember for the exams. So how do we manage these patients? Well, on a chronic basis, we have to give them bronchodilators just like we did with the patients with asthma. And the drugs of choice now are the anticholinergics. Remember, the anticholinergics don't work too well with asthma or asthma exacerbations because we need quick relief medication in that case. Well, here they work better because they're longer acting drugs, right? They don't give you that quick relief right away, but they act longer. And also because they don't have a lot of side effects. Remember the beta agonists? Well, one of the things that they do is they cause tachycardia. Now, if you give it to an asthmatic patient, young, otherwise healthy patients, the beta agonists don't bother them. But in these populations, they got subclinical heart disease, you give them a beta agonist and you cause tachycardia, this may affect them. So the first line drug in chronic obstructive lung disease, the preferred drug is inhaled ipratropium, and that's the way we start off with. We may use beta agonists along with that. In fact, some of these, the inhaled systems they combine both the beta agonists and the anticholinergics at the same time. But generally, if they ask you what is the most effective bronchodilator in these cases, then the answer is ipratropium, anticholinergics. Beta agonists we add on or we use as a secondary drug, especially because they have a little bit more side effects. In this population, these people have a lot of comorbid conditions. Theophylline is a big deal lately. Now, theophylline has gone through different phases. Everybody was using it 30 years ago, 10 years ago, people fell out of favor. Nobody's using it. Now people are starting to add on, again, because they see that theophylline is a great drug in terms it makes the patient feel better. It is not a great bronchodilator, but it has some other effects. It has a cardiotonotic effect. It helps with retraction of the muscles, the diaphragmatic muscles, so your diaphragm works better for breathing when you use theophylline. So it does a lot of other things that the patients find to be beneficial. Bottom line is this: add theophylline only when the other treatments don't prove to be as good. So let's say you put the patient on anticholinergics and then you add beta agonists and the patient still has symptoms, then you say, okay, let me use theophylline. A word of caution: if a patient's taking theophylline already, it's probably best to let him or her continue the theophylline. Once the patient has been using theophylline, they feel better. If you take them off the theophylline, they feel it right away. And they feel like their lung disease got worse. Even though it doesn't decrease morbidity, it doesn't decrease mortality, it does none of these things. So we're going to talk about a little bit later what things do decrease morbidity and mortality. Despite not doing all that, the patient feels much better. So if a patient is taking theophylline, let him or her take theophylline, continue to take it. If they're not taking theophylline, hold off. And if the rest of the medication doesn't do anything, then add on theophylline. Please be careful because theophylline has toxicities. And it also has a lot of side effects when you combine it with other medication, especially mycin antibiotics. So there is you increase the levels of theophylline when you put somebody who is already on theophylline on erythromycin and other mycin antibiotics. The other mycin antibiotics is not as bad as erythromycin, but you have to be very careful about theophylline toxicity in these patients. So be careful of that. Also, theophylline levels are decreased in patients who smoke. So they ask you sometimes, well, you know, your COPDer who has stopped smoking 3 years ago now comes in and feels worse, and the theophylline seems to not work. And it was working in the beginning, they felt really good, and now it stopped working. What do you think about in these patients? And the answer is they started smoking again. Very interesting, but smoking decreases the levels of theophylline, so they get subtherapeutic levels in these patients.